we have the pleasure of hearing. Recording in progress. Today, we have the pleasure of hearing from Dr. Natya Raghavan and company regarding a collaborative effort that was made for a challenging case. Now, I think most of you know Dr. Raghavan through her leadership role with respect to COPD management within the city and with the respiratory rehab program. She went to Queen's, she came to McMaster for respirology. When she went back to Queen's for additional training in respiratory physiology with a focus on COPD, and she practices both general medicine and respirology, does exercise testing. And I guess was faced with a situation that was outside her usual day-to-day, but really within our specialty. There was a collaborative approach that some of you may have come across in our provincial WhatsApp group as well on how this case was eventually resolved, or at least parts of the story. We don't have the whole story. So I look forward to hearing it. We're going to be hearing, I think, during the talk also from Taryn Sims and Eldar Priel. What we'll do is they'll provide their presentation. I'm not sure what to expect. I think it'll be enjoyable, and then we'll have some time for discussion at the end, and I can sort of moderate the questions. So everybody, please enjoy. Oh, okay. Apparently the technical difficulties continue. So Natya is joined as an attendee with 2 logins, and hopefully, there we go. Now she's got both her logins going. She's going to have one for video and one for audio. All right. Good luck. Can we hear you?
Can you hear me?
Yes, we can. Success. Wonderful. Okay, everybody, please enjoy.
Sorry, I need to share my screen. There we go. Can you see my slides?
Yes, we can. Yeah.
There we go. Okay, sorry about that. So this presentation is something I'm totally out of my comfort zone, which is why I chose to talk about this. I had a few interesting foreign bodies last year, and then Dr. Sims was my inspiration because she went above and beyond in terms of how she approached her case. So we'll start with her case, and then I'll talk about how I've dealt with my lack of experience in this area. So my only disclosure is that I have some research funding from BI, which is not relevant to this case. And so what we'll do is we'll start by exploring an interesting case of a foreign body in the airway. That'll be Dr. Sims. Then I'll take over looking at a bit of the evidence for fiber optic bronchoscopy for foreign bodies. And then we'll look at different tools available for us specifically here locally that we can use with the fiber optic bronchoscope. The case conclusion will be by Dr. Priel, who will join us there and provide some pearls and insights given his the training he's done over this last year. And then if there is some extra time, I will tell you about the couple of cases that I saw that I kind of navigated my way through without all this knowledge. So I'll hand it over to Dr. Sims.
Thanks, Dr. Raghavan. So the case starts on a long weekend on call at Juravinsky. Dr. Raghavan, I think you're controlling the slides? That's great. Okay, so it's I got called by a medicine resident about a 75-year-old woman who had actually been in hospital for 6 months. And her x-ray that evening had commented on this radiodensity that was present, suspicious for a foreign body. Next slide. So we can see here that there is this radiodense lesion. I'm not sure if everyone can see my mouse, but projected over essentially the left main stem there, and in the background of a left hydropneumothorax with a pigtail in situ. So I was wondering, what is that? So went back a day and it looked, I don't know how well it's projecting, but there's kind of these like 3 things stuck together that looked little bit sort of teethish to me. So if we go to the next slide, just changing the penetration and zooming in a little bit, you can see here that it sort of looked like something that perhaps that was dental in origin. So not being a dentist or having much in the way of this work, I'm not sort of familiar with all of the different, crowns and root canals and all that. So did a quick lit search. And in the GI literature, found something that looked quite similar to this object on X-ray. And this is something that was actually swallowed rather than, or ingested rather than inhaled, sitting in the gastric antrum. And I thought it looked a lot like that. So the leading hypothesis was the object perhaps is a 3-unit bridge. So going back to this patient, so she had a lot of comorbidities. She had a stroke in 2018 with some residual hemiparesis and potentially affected her swallowing function. AFib, pacemaker, as you saw on the chest X-ray for tachybrady. She had a prior PA arrest in 2015 due to DIG toxicity, and CHF, hypertension, diabetes, as well as a seizure disorder. And these are just a handful of her many comorbidities. And she had been in hospital, as I mentioned, for 6 months. So she initially presented with sepsis due to non-operatively managed diverticulitis. And that was complicated by acute kidney injury, and which she didn't recover from and ended up on dialysis. When she presented, as I mentioned, she had that seizure disorder and was found to be in non-convulsive status. She had lots of complications, including DIC, was in the unit for quite a while, and was trached, as you probably also noted on her X-ray. From a pulmonary standpoint, she had a Pseudomonas VAP. She even had an invasive fungal infection with pulmonary aspergillosis, evidenced by positive aspergillus, as well as a strongly positive BAL galactomannan and a bit of a micronodular pattern on her CT. And along the way, in the setting of volume overload, had bilateral pleural effusions. But the left one became a bit ugly and was adjacent to some consolidation. So evolved in a perimonic fashion with some loculation, smooth enhancement, had multiple pigtails, complicated by that left hydropneumothorax. You saw grew enterococcus at one point as well. So she was really in and out of the unit and never really off high flow via the trach. So back to the foreign body, it actually wasn't new, and it was noted on multiple previous studies retrospectively. And it's always easier to kind of see back with a retrospectoscope. But I think that another learning point I noticed, and I collaborated with a radiologist to sort of give them a heads up as well, just from a QI perspective, is that it was likely due to what's described as a satisfaction of search error. And this is the second most common type of error, and or at least perceptual error that can occur amongst radiologists, who I'm sure are also burnt out from the pandemic as the physicians on the clinical side. And it's, you kind of think your brain might say, well, there's so many abnormalities, like how could there actually be more that I need to search for? But going back, if we go to the next slide there, we can see 4 weeks prior was the first X-ray where this was visible. And you'll notice that it was in the right mainstem at that point, just asking for us to grab it. So easy at that point. But in fairness, this was reported actually. But it was reported as a, excuse me, 1.8 centimeter hyperdense structure projecting over the lower SVC, which might be external. So I think perhaps what happened in ICU rounds is it was probably maybe acknowledged and dismissed. Oh, that's probably just something on top, and in a patient with such a long stay, like sort of a quick round. And so it was reported, but just sort of not really identified at that point. And she didn't really have any plain films, just to perhaps conserve radiation resources, but had some CTs though to keep an eye on the effusion. And we can see here in a subsequent CT, you could see that streak artifact of this metallic object sitting on the right mainstem, sort of similar to that streak artifact you see from the pacemaker on the left. And there's some other findings that were occurring, this evolving left pleural effusion. There was interval changes in her parenchyma. There was some mild lymphadenopathy. There's lots of tubes and lines and everything like that. So it's, it seems surprising in retrospect, but wasn't really mentioned in this report. And then there was a subsequent follow-up CT. wherein now it's in the left side. So we can see here on the top left, there's been an interval development of really dense consolidation with those air bronchograms and a hydropneumothorax, and there was some attention that the pigtail had been dislodged at that time, but we can see that there is some volume loss as well, and some ipsilateral mediastinal shift, and it's clear that, you know, post-obstructive pneumonia process was occurring, and not surprising, the patient was getting clinically worse with increased FiO2 requirement and rising white count. So the poor resident who called me on that Saturday evening was resuscitating this patient kind of all day, and I kind of nudged things along to get her back into the unit. And when I went to meet the patient, this next slide, on exam, the son told me that she had been having quite marked bruxism. So she was really grinding a lot. And so the patient wasn't really communicative, level of consciousness like wavering a bit. So, and trach, as you saw, so she, on exam, you know, when we were able to open her mouth, she had really loose teeth that were actually like frighteningly loose and sort of attached together from some prior dental work. And she was back in the unit, and in terms of what to work with, she had a 6.0 Shiley trach in situ, and she went from high flow back on the vent when she went back to the unit, so 18 on 8 with FiO2 of 40% and some light pressor support. So now the next mission was, how do I get this thing out? Because she's not going to improve unless I do. So I kind of phoned a friend, or multiple friends, as Dr. Tunks had mentioned earlier, and polled the Ontario Respirologists via WhatsApp that we communicate through on, you know, how, like, any strategies on how to get this out. And at the time, I wasn't sure actually what working channel I was going to be able to deal with. You know, what tools I could use to get this out, because it was quite large. So a lovely endo nurse came in on the long weekend, and we went scouring through all the supplies and looked into GI stuff to get a few things. And I also went down to the OR to get a stone retrieval basket, just in case that would be helpful. So I went and gathered all this stuff and ended up going through the trach, ready to decannulate if needed, to extract the foreign body with a backup trach ready. And the RT kindly bagged the patient for me during the procedure. And what I found here was this large impacted foreign body that is completely occluding her left distal main stem. So this is sitting in front of and obstructing the secondary carina. And you can see that there is this a porcelain aspect that looks kind of like a tooth, and then this kind of gnarly metal part. And so I cleared off some adherent mucus, and it found it really difficult actually to even kind of get in behind in there. If we go to the next page, I'll show you some of the tools that I tried. So tried the rat tooth forceps there on the top right. And I was able to kind of grab a little bit onto the porcelain side. But as soon as I would pull, you know, I could get resistance, but this thing was so impacted that it just wouldn't budge. The rat tooth was also not quite wide enough to get like a really good grip. There was a couple tries where I could latch onto that porcelain part. I tried the Rothnet basket at the bottom left, and I could kind of sneak in behind on that left side of it, but wasn't able to successfully sort of wrap around there. The zero tip one that I had mostly if I needed to go down a smaller working channel was not, would slip past it once I would really yank. And then the tripod one at the bottom was just sort of fairly useless. And unfortunately, I wasn't able to have a balloon that I know can sometimes be helpful if you can get behind it, just because I couldn't find one both in the OR or endoscopy suite that was going to be small enough to fit down my working channel. And nor did I have a snare due to adequate size. So essentially, I really tried, having invested a lot of planning into this, and was determined to get this thing out. But there was a lot of bleeding. Like as soon as I cleared my working channel and started putting the instrument down, and my field would be pretty much occluded. So I had to use a bit of epi and cold saline, and ultimately really sweaty half an hour of determined attempt, and then called it. Called back thoracics, and at that point it was Dr. Finley on, and had to sort of phone a friend, and ultimately the decision was to take this patient to the OR with some tools that were available over there at Joe's. And so we'll come back to this case with Dr. Priel in a bit. Thanks, Natya.
Thank you. So that was the inspiration. So when I started looking into this, I wasn't sure what I would find. I didn't actually expect to find much. There is, as you can kind of expect, that there's a lot more in the children pediatric literature, but less in adults. But then there was a surprising series of articles from the Middle East with young women aspirating pins. And one of these was particularly interesting because they kind of did it prospectively. Because of the pin and the danger of lodging into mucosa and then subsequently causing potentially more damage. This was back it was published in 2000, but they collected data for 3 years. So at the time that they started, rigid bronchoscopy was actually the standard of care for dealing with a foreign body like this. So this was in a group from Jordan. And so they felt at the time that they were starting that rigid bronchoscopy was the standard of care, but they had noted a few prior retrospective series with success of fiber optic bronchoscopy. And obviously in terms of, needing OR and general anesthetic, it would be far superior to do a fiber optic bronchoscopy if it could be done successfully and safely. So here they developed a protocol to evaluate the success of fiber optic bronchoscopy for pin retrieval from December 2002 to December 2005. And this is an example of what these pins look like. So it's a sharp pin with a kind of rounded pearl top. People generally put them in their mouth, sort of round tip in. So when it gets aspirated, the round tip ends up distal and the sharp tip is what's pointing up at you. These are the tools they use, which now look familiar because they're the same ones that Dr. Sims was using. So there's a basket here, grasping forceps and rat tooth forceps. And those were the 3 that they had in their protocol. And all patients underwent bronchoscopy on the same day of referral, and they were using an Olympus PF type bronchoscope with a 2.8 millimeter channel. So they developed their protocol. So their plan was that you look at where this foreign body is, choose whichever tool seems to be the most useful based on, kind of what's looking out at you, get a firm hold of the pin, and then withdraw the grasping instrument to the tip of the scope, and then take the scope and the instrument out altogether. And then they would go back into the airway to inspect for any damage or bleeding or anything that happened. So that was their protocol. And what they found, so they actually over a 3-year period had 16 cases. So this is a fairly significant number, I would say, of these foreign body aspirations. They have the ages there, so mostly young women. Their catchment area was an area of about a million, and it was a 400-bed hospital. So it wasn't, a huge area, and they still had this large number of foreign bodies. And you can see the tools they used. Mostly they were using the forceps, either the rat tooth or the biopsy forceps. And then I'll highlight these. There were only 3 that actually needed rigid bronch. All the others were successfully removed, although a couple were slipped and then swallowed. And then 1 patient actually needed a thoracotomy, and I'll get into more details there. So this is what the pin looked like. So often, it would be quite embedded with granulation around it, just because of the sharp nature of the tip of this. And so 56% were immediately successful, so 9 out of 16 that they got the pin out right away. There were 3 more that were dropped, mostly in the oropharyngeal area, and then they were swallowed just because it was conscious sedation and a nice round tip. So before they could catch it, the patient had swallowed it. These patients were treated with immediate endoscopy to retrieve the pin in the stomach. And initially I thought that meant that the bronchoscopist was actually doing an endoscopy, but they actually stated that they needed GI on site to be able to manage this. So I think it was an emergency call to GI who came in right away. So overall, if you combine those, they had a fairly good success rate of 12 out of 16, which was 75%. There was only 1 case, as I mentioned, that required a thoracotomy, and they felt that part of that was because of a delayed presentation. So this patient only came 13 days after the actual aspiration event. So it was quite granulated and ingrained in there. So even a rigid bronch was unsuccessful in that case. So after that, I found this, which was looking at a retrospective review over a long period of time of 26,000 bronchoscopies, and then a systematic review of the literature. So just to understand a bit more about the role of bronchoscopy in these foreign bodies. And this was published in 2015. So here, this was in India, where they did a retrospective review of all flexible bronchoscopies done at their single center from quite a robust time period, 1979 all the way to 2014. And then to add to that body that they were looking at, they also did a systematic review of any studies that were looking at foreign body removal in patients who are more than 12 years old, and any series that included more than 10 patients. And on their retrospective reviews, so they had a large number of bronchoscopies. So out of that nearly 26,000, when they reviewed the charts, only 65 were done for a foreign body, which makes, kind of makes sense if we think about all the indications for bronchoscopies. And out of the 65 patients, 60 recalled an inhalational event. 5 were detected on imaging. So either they had a decreased LOC or they just didn't remember the event. And out of those, so 16 out of the 65, it was actually diagnostic on chest X-ray that you could actually see the foreign body, which only accounts for about 25% of this. But quite an interesting array of foreign bodies. They had metallic ones, pins, screws, whistles, a lot of organic material of nuts and seeds and various things, and then even plastic materials like pen caps. Out of the 65, 49 of them had the foreign body actually identified during bronchoscopy. It begs the question of what happened to the rest of the patients, but unfortunately, because this was a retrospective review, they couldn't actually identify what happened to the other patients. So what they did was just included the data from those 49 where the foreign body was actually identified and seen on bronchoscopy to then look at the successive retrieval, because you obviously can't retrieve an object that you can't see. So 45 out of the 49, which is adds up to 92%, actually had foreign body retrieval by fiber optic bronchoscopy. The majority of those, so 41, were done just at a single attempt where they were able to get the body out. 4 required a repeat procedure, so they had to go back either because it was an organic type material where not all of it was retrieved, or because they were unsuccessful in the first attempt. Out of the remaining 4, 2 required a rigid bronch, and then 2 others were lost to follow-up. So again, I'm not sure what that means, and it's just the limitations of this type of study. And these are the patients. So again, they're fairly young. I mean, the average age was 32. This is just the chest radiograph data that we talked about in terms of the findings. So only that 25% you could actually visualize the foreign body, but there were a lot of other abnormalities such as non-resolving pneumonia or atelectasis or lobar collapse, which makes sense in terms of what we're talking about. The location is specified here with, again, a slight right-sided predominance, as we know. And then most interesting, I think, to our discussion here is what types of forceps they used. So they had a shark tooth forceps, alligator, rat tooth, and then they had a basket. They also had magnetic forceps. And then there were a few that were just not reported because it wasn't detailed in the charting. So in terms of complications, 11 of these patients had granulation tissue, and then 8 had significant mucosal edema, and then 3 had significant bronchial stenosis of greater than 70% of the airway. The granulation tissue and mucosal edema were treated with prednisone, 0.5 milligrams per kilogram, that was tapered over 3 weeks, and they all had good response. The bronchial stenosis was managed with balloon dilatation, and 2 out of 3 had minimal residual stenosis, estimated at around 20%, but there was 1 that had ongoing 80% stenosis of the right middle lobe bronchus that was resistant to the dilatation. Most of these patients, so 89%, were discharged on the same day. So they presented with the foreign body fiber optic bronchoscopy done and then discharged home. Then when they looked at the meta-analysis, I won't spend too much time on this, but just collected some of the more interesting points. So it was 18 studies included with a total of 1,554 subjects. So the proportion, again, similar to their own group, was 0.16 to 0.33% of patients who actually need a bronch for a foreign body. The success rates range from 61 to 100%, and pooled all together comes out to 89.6. So around 90% is what it seems to come out as. The remaining foreign bodies were retrieved by rigid bronchothoracotomy. There were some patients who refused any further treatments, and some patients who had the procedure and then coughed out the foreign body post-procedure. So presumably it just got loosened up enough that they were then able to cough it up. In terms of complications, again, bleeding was the most common. There was some hypoxia. There were some cases of migration to another bronchial segment. There was slippage into the GI tract, and then a couple of transient hypotension or low-grade fever. So what do we have available to us here? So we already kind of heard that. So, you know, the same scopes that we have at Juravinsky. So I have the data for HHS. So at the Hamilton General, we do have three scopes. Two of them have the large 2.8 millimeter channel. One is our pediatric scope with the 2 millimeter channel. And then at the Juravinsky, they have three scopes, all with the 2.8 millimeter channel. They do have a pediatric scope, but they've put it away and it's not being used. But again, good to know, because if you're dealing with a small size trach or something like that, it is good to know all the tools that we have available to us. We can discuss more. Dr. Pale can inform us of what's available at St. Joe's. I do believe there's at least one or two of the large channel scopes available at St. Joe's. There's also a cupboard here at St. Joe's that contains all of the more advanced tools. So in terms of the forceps and everything we'll be talking about. And then at all three sites, if you're doing an urgent procedure in the ICU or the emergency room, you'll need to call the endoscopy nurse on call so that you can get the cart and that you can get all of these tools that are available in the endoscopy unit, because certainly they won't be available anywhere else. So in terms of the tools, the rat tooth forceps, so what HHS now has is a single use combo. So it's a rat tooth and alligator grasping forceps combo. And where you find it is on the ERCP cart. So it has both that rat tooth kind of ratcheted thing plus the grasping, so 2-in-1 to hopefully grab onto these objects. And it fits into the 2.8 millimeter channel. Then the Rothnet basket that we've actually seen already. So again, just a basket kind of one-sided so you can swoop it around and try to get hold of this foreign body. Again, fits into the 2.8 millimeter channel. It is available in endoscopy as well. Snares, so there are many different sizes of snares that all fit in the 2.8 millimeter channel. They come in 10, 15, 20, and 25 millimeter sizes. I think the size is measured in the distance this way. This is usually used for polypectomy. So as you pull back, it kind of narrows, and that's how they grab hold of the polyp. But we could use it for our foreign bodies. Again, should be available in endoscopy. There are other tools that are not readily available. So the baskets, there are a couple of different baskets, as Dr. Sims mentioned. So the zero-tip nitinol basket is available in the OR because they use it in urology for stone retrieval. There's a tripod basket as well. So these are not officially approved for endoscopy. I was speaking to our procurement person at HHS, and she's happy to source any of these for us if we'd like to have them on standby. So happy to hear about everyone's thoughts kind of as we have our discussion at the end of today. There's something called a ratcheted grasper that we don't have either, and then a magnetic forceps. So if we think of these metallic foreign bodies, a magnetic forceps might be key, but again, you know, we don't have a large number of these, but again, the procurement person was quite interested when I was asking her these questions, so was going to source it out and find out if it is available. So now to go back to the case, since you're all probably on edge to find out what happened to our poor patient, I will hand it over to Dr. Priel.
So thanks for the invitation to take place in this presentation. So Dr. Finley was the surgeon on call who received this consult and eventually did the procedure, and I was privileged enough to join him in the operation room. Next slide, please. There are several ways to plan this this sort of procedure. What we planned to do is to do a flexible bronchoscopy through the trachea, through the tracheostomy, sorry, and use one of these tools that you've already seen several times today to try and retrieve that that dental bridge. Another thing that is theoretically at our disposal but hard to find in endoscopy, as you've heard from Dr. Sims, is a Fogarty balloon, which is something that you can traverse distal to the lesion itself and then inflate it and pull it back, and that is better for more distal placed foreign bodies. In this case, we didn't plan on using it because this was more proximal and because we saw Dr. Sims's report. So we planned using these three devices that you can see on your screen. One is the Rothnet basket, which we arranged several sizes of. The second one is the rat tooth and alligator tooth forceps that we didn't end up using. And the third one is the snare. When you prepare for this procedure, it goes without saying that one of the first things to look at, and please click the button, is the diameter of the scope that you need to use. And you see that for two of these, you need to use a therapeutic scope. You've heard what's available at the Jaravinsky and at the General. At St. Joe's, there are two therapeutic scopes. One is 2.8 and the second one is 3.2, I believe. Well, actually, there's three scopes. There are two of the 2.8 and one of the 3.2. And there's also the regular scopes, which are smaller in size. So what you want to do, you want to get distal to the foreign body, then inflate your basket, and then kind of maneuver it so it traps the foreign body inside, and then kind of deflate like a lasso, and then the thing is caught inside. Next slide, please. And this is what we attempted to do. I found this thing, which is kind of interesting. This is the first, on the left side on your screen, this is the first in man report of retrieval of a dental bridge by a wire basket. Now, unfortunately, we were not able to pass the basket distal to the whole dental bridge. And while we tried to get it from the side, we did not succeed in doing so. What you don't want to do is push it distally inside and then cause impaction. Before I proceed, one last word about the forceps biopsies, the forceps use. So you've heard us talk about the rat tooth and alligator tooth, and not so much about the regular biopsy forceps. And there is a reason to that. And the reason is that the biopsy forceps are cutting. And what was seen in the past is, especially when you use those for organic material like peanuts or cashews, it just breaks down. So these rat tooth and alligator tooth are better for taking flat objects. And while they do pose the same risk, it's lower because of the design. Next slide, please. So as you can see here, we ended up using snare, and this is the foreign body. And Dr. Sims spoke at the beginning of her presentation about satisfaction of search. So I think there are two satisfied people in this selfie that Dr. Finley took at the end of the procedure. Of course, when you go into a procedure like this, there's a plan B, and the plan B in this case, if nothing would have worked, was to proceed with a rigid bronchoscopy. Using a rigid bronchoscopy gives you a lot more spiel to use more aggressive and more strong devices, because you can traverse things in parallel. You can use two tools in parallel, and you can use the flexible scope to visualize better, and use the tool, and you're not limited by the internal diameter. And the last thing I wanted to speak about is a technology that is not available here, but is used more and more in the world for foreign body retrieval, and that's cryoprobe use for foreign body retrieval. And I believe that David Youssef spoke about that a few months ago, and that is very good, especially for blood clots and foreign bodies such as this. So thanks for including me, and that's all I have.
Could we, just before questions, go back to Elder's slide where he showed the different tools and the one that did succeed? So you'll see there, this is, so Dr. Priel, this is a colonoscopy tool, right? I see the colon there.
Yeah.
So that's an interesting point, because I was looking at all the OGD stuff, not C-scope, and I wonder if, because I couldn't find a suitable snare, so that's just something that maybe is a not totally intuitive, that there is this large snare available amongst the colonoscopy tools. That's quite interesting.
Yeah, so it's not intuitive at all, and you know, the companies may manufacture things that are specific for a bronchoscope or specific for an OGD, but basically, if it fits in the channel and it does what you want it to do, you can use it.
That's awesome. And yeah, I had asked, I was after the frustration, I did ask Dr. Finley I said, please make sure you take a picture. I've got a lot of people asking for updates. And then so he sent the selfie for.
That was terrific. A good collaborative approach there for dealing with a challenging case. There's a comment or a question that has been sort of partially addressed by Dr. Priel, but he may want to elaborate more. What are the thoughts regarding cryoprobe?
Yeah, so I don't know. Did you finish the presentation?
So I think we might as well do discussion now. I have the extra cases if there isn't a lot of discussion, but those are kind of bonus. So why don't we chat now to get everyone's perspective? Because I think this is kind of the crux of things for us all to talk about it. And then if there's still time, because we still do have a good amount of time, I can go through the others.
All right. So I started talking about the cryoprobe. I naturally don't have any experience with it. I've only seen it, but I think if cryoprobe is something that eventually gets brought into the city, it could be utilized for this as well. There's preliminary evidence that it does very well with foreign body retrieval, recanalization of stenotic airways and obstructed airways, as well as blood clot retrieval. So I don't have a lot of experience and expertise in this to comment, but on paper, it looks like it's a promising thing to use. The problem with something like cryoprobe and the advantage of things like you see on the screen right now is that for these things, you don't need specialized training. You just need a good approach and some know-how. And I think that everybody can do it. With cryoprobe, I expect that there's going to be some specialized training, and therefore it's going to be, even if it's available, it's not going to be as available for emergent things.
Terrific. Next question is from Dr. Duong.
Thank you to all three of you. That was a really wonderful and enjoyable talk. And I'm glad it wasn't me that was on that long weekend. The question I have was that you presented data using steroids following the procedure to reduce the swelling. Is there any advantage of using before to reduce the swelling around the impaction or the foreign object, so that that will allow you more space to advance your equipment or the apparatus distally? Is there any advantage doing that?
So I mean, most of when they go through these case series, it seems like your greatest chance of success is being as quick as possible. So I think for us, there might not be a lot of time. There's certainly no evidence. And then even with those 3, or I think it was 11 cases where they treated with steroids post for the granulation tissue, we don't know if they would have just healed on their own, right? So they got better, but I don't know how much was the steroids versus not, but it was interesting that they did use that. Again, I don't know if Dr. Priel has any thoughts about this, because I guess between the two procedures for this patient, there was a bit of time, right? So whether anything could have been useful. I think the other concern, though, is the infection, because this patient had a significant post-obstructive pneumonia. So I don't know how comfortable we'd be with steroids there.
Right.
Yeah, I haven't seen anything about this. The only thing that I can comment on is that when you do, when you need to do explantation of valves for COPD, it's not, I think it has not been proven useful to use steroids for that indication to reduce the amount of granulation tissue. And I'm not sure how much inflammation is there, but I don't know any hard data to support this.
Thank you.
I don't want to go off on too much of a tangent with my own question, but obviously epinephrine has the advantage of reducing edema as well as stopping bleeding. But when the bleeding doesn't stop with epi, there's sometimes vasopressin. But if you're also hypertensive, then where do you go? I know there was some stuff a while back about giving tranexamic acid through a bronchoscope. Is that something that's available in any of the endoscopy units in Hamilton? Is that something any of you have experience with?
I don't know, but I can find out. I don't know if anyone else knows.
I've looked into it once, and people were not very supportive. I don't think that we have it in the drawer to use, but I think you can just use the one, and if you know how to dilute it, you can use it through the bronchoscope, but not as a fellow.
So when you nebulize it, you don't dilute it. It comes in a 5 ml jar. So you probably wouldn't have to dilute it giving it through a bronchoscope. You just have to, it's just a matter of quantity.
When I think of tranexamic acid, I think of CF, and indeed, Dr. Corvo has said that she's asked for it before. I don't know if Sophie, you could type or be unmuted, but have you used it elsewhere or seen it used, or comment on use through a bronch?
I've never used it through a bronch. I asked once when I had significant bleeding, and they're like, we don't have that here. Like, what are you talking about? So yeah, I've used it in like hemoptysis and CF, usually oral or inhaled, but I've never used it through bronchoscopy. But my thought was sort of the same as Dr. Tunks. Like, if someone's bleeding, it seems like using this through a bronch would be helpful, but I haven't actually ever tried.
And Alder, I don't know how much epi you had to use in the OR, but I had to give it, I had to do a bit, and she was already in AFib, so I made her a little rapid by the end. But I mean, we were in the unit in a controlled setting, but it would be nice to have something, that is more hemodynamically neutral.
What was interesting actually for all of these tools was that I guess similar to Taryn's experience, when I went down and asked the endoscopy nurses, they kind of looked at me confused about what I was asking about. And it was actually when I talked to the procurement person who actually knew quite clearly what I was talking about and on which cart and where you could find all of these tools. And she was quite interested. She had heard about this case actually, because she had been on vacation and someone texted her. And she was like, what is this thing about teeth in the airway? So she's interested actually, and will, like I mentioned, was willing to source out things that we might think are useful. So, I have her contact, and I told her I would report back after the talk, because if there's anything that we feel like we should have at least available, and we wouldn't need multiple sets of it, we just need to know where it is and how to get it, right? So I'm happy to hear that feedback.
Jerry, have you used it in a bronch? So not in the endo unit, but.
Yeah, no, I've never used it down a bronchoscope,
Okay.
but no, I haven't. But it is usually in our pharmacy. We've used it a couple of times on inpatients and actually on an outpatient, nebulized in an outpatient. So, but I've never thought of putting it down a bronchoscope.
But say if we can't if there's too much red tape to instill it through the bronch, I wonder if there would be a role of having the patient nebulize it prior to the procedure. I only have oral experience, admittedly. Does anyone think that might be helpful, or?
I don't think there should be any red tape, really. It's just a matter of ordering it up from the pharmacy. It's being delivered by the MD. There are a number of medications where there's policies about who can give things, but physicians can get away with giving a lot of things
Yeah.
that the nurses can't. So it's really just a matter of ordering it up from the pharmacy instead of asking, the nurses what they would do. We have to just kind of,
Do it.
just kind of do it.
So the other thing I've seen somebody use here was cold water saline lavage.
Yeah.
I was beside Weil Hannah one day, and he thought of using that. That should be more available than more immediately available than tranexamic acid in our endo unit.
You'd think so, but I put mine on ice for a couple hours before I did the procedure, and that's like the only saline that I was using was cold, but it's not readily prepared, which at least at the JERV, I don't know if they have it readily available for all procedures at Joe's.
No
So
idea.
Did you go to the ice machine and gather up some saline bags and put them on ice yourself?
Luckily the nurse was kind enough to do that for me, but I gave instructions. I was like, I need that in the fridge on ice. And we had a couple delays because there was an unstable patient who came in when we were going to get started. So it was nice and cold.
So Alec Campbell's been waiting patiently.
It's been great discussions. I have no complaints. I was mostly just wondering if anybody has experience or tips or tricks about dealing with, particularly aspirated food. My worst foreign body cases have all been food that's gotten stuck down there. That's sometimes been there for a little while, and I find that every case that we've had this, we've tried to get it out, and it's just kind of turned into mush. Which is kind of an effective clearance strategy, because if you get it into small enough pieces, then the patient can cough it out. But I was just wondering if people have something that's better and doesn't lead to the patient coughing like they're dying for like 4 days.
I'm not sure if Elder was going to go for that one, but I think his point about avoiding forceps is a good one for organic material. I would imagine that a Roth net or like that basket approach might be ideal, so you can get behind it, scoop it up, and then tighten it up and pull it out. But Elder, do you want to weigh in on, or Natya, weigh in on that one?
I was about to say the same thing. If it's really distal and you can't, for some reason, can't get it, you can try and use a Fogarty balloon just to block that airway. But I think that's a good approach. I would use a basket as a first step if I can.
Yeah, again, so one of my bonus cases was a Septra tablet that was in the the bronchus intermedius, that my greatest fear, because it had already been in for a couple of days, was that I would break it up and then there would be Septra all throughout the lungs instead of just in a major airway. And so I'm glad I've now done this, but I wish I'd done it before, because the basket would have been perfect. The way I got that out went distal, because I could get past it with the biopsy forceps and pulled back. So it ended up high in the trachea before I lost it, and then we sat her up and she coughed and got it out. But I think that was a suboptimal approach, and now after this talk I think I would have approached it with a basket.
There's, I guess, good old suction. Dr. Beeman has commented that he's dragged lettuce out just with suction. So I think the key too is, I admittedly, when I would bronch, I would just use the bronch that was handed to me, but now I always want to make sure I've got that 0.8 working channel when I'm anticipating like thick mucus plugs, or want some really good suction. So I would advise that as well, just in case it's mobile and something that could adhere to the end of the scope.
I thought I had a picture of my Septra tablet, but it's somehow hidden in my technical difficulties today behind the CT scan.
All right, did you have, you said you had a couple of bonus cases.
Yeah, well, we've talked about this one. So this was the Septra tablet lady. So she presented, 60-year-old, with a history of lupus and granulomatosis with a palate defect. So she knew she aspirated things and tried to be as careful as possible, but trying to take her Septra tablet aspirated it. This was her x-ray on presentation. This is a previous baseline x-ray, so you can see that she really has had collapse of the right lower lobe there. Interestingly, overnight, so this is just a bit of, the culture, she ended up with the CT before I was even called, even though they actually, she actually said, I aspirated a tablet and it's in my airway. But there you go. So they saw the tablet in the airway before I was called. And then this is the one that I just described. So it was one of these things where you kind of rush in and say, that the suite was available. And so we just rushed her into the bronchoscopy unit without much time to think. And my thought was, well, I'm just going to look and see what it looks like. I wasn't very confident that I would want to touch this again for concerns raised before. But then was able to, with our usual biopsy forceps, just get distal because it was a tablet, so I could get past it and then open up the forceps and pull back. So that was one that had a good resolution, and she did well, and the Scepter tablet is behind the CT. The other one, which just tells us why, we shouldn't really wait for these things. So this was an unfortunate kind of moving together of, COVID, and it was April 2021. So that terrible time when, our healthcare system was really falling apart. This lady was a 68-year-old lady who came in post-tibial plateau fracture, went to the OR. In the OR, they asked her, as they usually do you have any loose teeth? She said, yes, I do. So they intubated her, did the operation, extubated her. Her loose tooth was missing, and she didn't tell anyone because she said, well, I told them the tooth was loose. So when it was missing, I figured they knocked it out and threw it out. Unfortunately, they knocked it out and it was down in her airway. She recovered from her initial OR, went to the satellite health unit because of mobility issues, and then was having a nagging, persistent cough that wasn't going away. And because it was April 2021, she was swabbed for COVID, ended up being COVID positive, and was transferred to the Hamilton General COVID unit. Once she arrived at the COVID unit, they did an x-ray to see how bad her COVID pneumonia was. And that's where they found this tooth. So when I went and asked her, she said, oh yeah, I know I lost a tooth. And there it was. So again, this was, I guess, as these things always happen, it was like 4 or 5 p.m. on a Friday afternoon during COVID, where she had just tested positive. So there were a lot of infection control issues of where I could take her and what I could do. The charge nurse pulled a lot of strings because they were taking a patient out of the COVID ICU. And so we took her down to the COVID ICU to attempt, but this was really wedged in. A single tooth. And then I was using ICU bronchs because I couldn't bring endo bronchs because it was COVID. Not that I think I would have been that much more successful, but yeah, it was a Friday afternoon with myself and ICU, Dr. Ainsworth doing the conscious sedation and us trying to poke away at this thing where we were just unsuccessful. So I eventually gave up, got on the phone, called thoracics. It was Dr. Exarian who was on, but then he was again saying, I don't know how I'm going to bring this person over from the general to St. Joe's for a procedure during COVID. And she was stable. I mean, she just had a cough and was just on a bit of, I don't think she was even on oxygen actually. So the plan was, this has already been in for, I think it had been a couple of weeks. Let's wait for the COVID to clear, bring her over to St. Joe's and do the procedure there, which I think was the only kind of route possible because we all lived through this and know what happened during COVID. But unfortunately, so it was extracted in May, and this is in December. So a couple of people here, including Dr. Raymer, are now looking after this patient. You can see that even though they did successfully on a fiber optic bronchoscopy get the foreign body out, that 1 month of the foreign body wedged in there has left its mark there. So evidence of bronchiectasis that you can see even just on that x-ray, and significantly bronchiectasis on this CT. So just, why we do need to be a bit diligent and I guess persuasive and try to get these things out. I think, system wise, I don't know what else could have happened at that point. That was, when we were on the breaking point of the ICUs at that time. But just, why it's important to think about all these tools and what we can possibly do to provide care. So that was my conclusion, that there actually is some evidence and even some local success that fiber optic bronchoscopy can be a useful first step in a foreign body. There are a lot more tools, I think, than at least I knew about, and that are available. So we need to ask for them. And now that we have a bit of a list, I think that's helpful. And these cases are all time sensitive to avoid complications. And then our IP and thoracics colleagues are certainly helpful in terms of our phone a friend for challenging cases and can help us when we are unsuccessful in these attempts.
Terrific. That was a fantastic talk. I really appreciate all of you joining in this presentation. I think that really added a lot to have the different roles and perspectives and some additional cases to talk about. And thanks for including some time for discussion, because it was a great discussion as well. So thank you very much, everybody. Thank you for joining us, and thank you for joining the discussion, and have a great day.
Thank you.